we have some experts here. We have a 5-panel presentation for you. And what these folks are going to do with us today is obviously share some of the challenges that they have, but also share some of the resources and strategies and things that they do, the collaboration piece of it, why we've been able to do some of the things we do. And simply with limited resources, we are able to do that with collaboration. So I think I will just go ahead and let each of you introduce yourselves and where you're from, and then we'll get started.
It's a heavy mic. Good afternoon. I'm Nancy Jost. I work for West Central Initiative. It's one of the 6 Minnesota Initiative foundations across rural Minnesota, and I am the early childhood coordinator there. And we started our Early Childhood Dental Network project in 2005, and it began in response to oral health needs that were identified by the Minnesota ECIs, which stands for Early Childhood Initiatives. And those early childhood initiatives were all surveyed to see what things were good or strengths in their community, what good things were going on in their community, and what things were a challenge. And oral health came up in all of our communities as being a challenge for young children. And our region includes 9 counties in west central Minnesota, plus the White Earth Nation. We have taken a 2-pronged approach to oral health. The first one is increasing access to oral health, and the second one is promoting education and awareness of good oral health. So our first prong, the increasing access to oral health, is done through our outreach clinics and 2 permanent dental clinics that are for low-income people. So the outreach clinics are held mostly in schools, and we see children from 1 to 18. There are 60 outreach clinic dates of service that will be provided through 2016, including restorative dates. And there are 15 total sites in the region, including those provided by all 3 of our service providers. And those providers are Children's Dental Services, Apple Tree Dental, and Caring Hands. And the ECDN was instrumental in opening a permanent dental or Apple Tree Dental Clinic in Fergus Falls, and Caring Hands opened a permanent dental clinic in Alexandria. And both see low-income people of all ages. Our second prong is the promoting of education and awareness of good oral health. And we do that through child care home visits. So we have someone go into child care homes and do education on oral health. We do lots of community outreach projects, and we send out flyers. We have all sorts of flyers and different communication forms that we send out. And then we do oral health trainings. So our ECDN membership includes a strong partnership from a multitude of sectors, including early childhood programs, our 10 ECIs, our 10 early childhood initiatives, and each of our early childhood initiatives covers the whole county. So that's why we have 9 early childhood initiatives. Well, we actually have 10, 9 in the counties and then 1 in the White Earth Nation. And we also have public health, nonprofit organizations, including Child Care Aware. Child Care Aware does our child care home visits on oral health. We have regional and statewide health departments and organizations, and we meet bi-monthly. In fact, one of the people on our panel was on vacation once, I think, in Mexico, and she called in for our meeting. So we have lots of dedicated people on our team. We have statewide partnerships with the Minnesota Oral Health Coalition. There are a few of our members that are on the board. We are involved with the Minnesota Dental Association and America's Tooth Fairy. And for those of you who aren't familiar with that project, it's a program of the National Children's Oral Health Foundation. And then about 3 years ago, the Early Childhood Dental Network, the ECDN, was approached by the Bremer Foundation to replicate our work in other parts of the state. So we are now working with the other MIFs, Minnesota Initiative Foundations, in southern Minnesota, central Minnesota, and southwest Minnesota. And so the ECDN now encompasses 46 of Minnesota's counties. So I think that's a little over half, maybe. And then one of the things that we didn't do for many years because we were working so hard on access and education and awareness is evaluation. We thought we were really accomplishing good things, but we didn't have it formally evaluated. So we have, in the last couple years, worked with an outside evaluator to assess the impact of our collective work on increasing access to care and promoting the importance of good oral health for young children. WCI serves as the backbone organization that we establish shared measurement, we build public will, work on that anyway, work on advancing policy and mobilizing funding. And this is done through support of our coordinator, Jane, and our wonderful partners at the table. Because without our partners, the ECDN would not exist and wouldn't be succeeding in our work. The ECDN has had positive results and progress in early childhood oral health measures in West Central Minnesota. For example, Head Start used to worry about non-compliance in reaching their oral health access goals for their children, and now I don't think anybody in our region anyway worries about it like they did before. So we have definitely succeeded in helping with that. Funding and sustainability. Funding for this much needed, well-organized, productive project has been relatively easy so far, but identifying permanent sustainable revenue has been much more of a challenge. So we're very dependent on grant funds, which nobody wants to be or can be on a permanent basis. So the MIFs have been instrumental in helping with that funding and to develop, expand, and evaluate the work. So we're thankful, and I'm part of one of the MIFs, but we're really thankful for the MIFs taking this project on. For 2017, our goals are to continue advocacy with legislators, encouraging dentists to see children at age 1, publicize and promote ongoing work that we're doing and recent evaluation of the ECDN, so we want to continue that, provide support and assistance with oral health education and outreach events, and we have many sightings of the tooth fairy in our region. She's really started liking our region. She comes to lots and lots of community events. And we also are continuing to participate in statewide efforts. So you might wonder why we concentrate on children 0 to 5, although in our outreach clinics we do see children 0 or 1 to 18. We started out with just seeing preschool age children, and we have we've been doing it for a few years, seeing children that are up to 18. Does that mean I'm done or I have a minute? Okay, all right. So the reason that we concentrate on 0 to 5 is because 80% of brain development happens in those first 5 years of life. So biologically, those are the years when we make the overwhelming majority of the neuron connections in our brains, and the first 5 years sets the foundation for our development and health trajectory for the rest of our lives. And that includes things like oral health, obesity, nutrition, physical activity, as well as academic development. If a child is in pain from oral health issues, it's difficult to learn, to explore their world, and interact with others in those critical years. Habits and behaviors are formed in these years, even habits of brushing teeth and going to the dentist. Children's talking, eating, and playing can be jeopardized by poor oral health. We've seen children put in early childhood special ed classes because they couldn't talk or wouldn't play, and it was all because problems with their teeth, and they were in pain. So once that was taken care of, some of their other issues were also taken care of. So children can also, die from oral health. So that's bottom line. We can't get these years back, and our children deserve good oral health in and of itself, and also because it can affect their brain development. These both have lasting, lifelong effects, and that's why we think it's so important to concentrate on 0 to 5 and prevention.
Hi, I'm Uli Sarvis. I'm a pediatric dentist and a public health researcher at the University of Minnesota. I have been in the state for about a year, and I am so encouraged by the initiatives and the value that the state places on early childhood interventions, especially oral health, because that's an early childhood intervention that often goes by the wayside. As a pediatric dentist, I see children who come in with lots of cavities. That's where I see in my clinical practice and when I teach residents and dental students. And treating children at a young age, under 6, is really difficult. You can imagine it's hard for an adult to sit for a lot of fillings, but if you're a child who's been in pain, who hasn't had the cognitive ability to sit through all these appointments because they just haven't been able to learn those skills, it can be really challenging to treat these children. So the adage that an ounce of prevention is worth a pound of cure is perfect for this situation. Children are also more susceptible to abscesses just due to the development of their teeth, the physiologic nature of their teeth. The infections spread really rapidly. We see children in the emergency department very often. I take call a lot for the university, and the parents will call in and say, oh, my child had a toothache for the last couple of weeks, but now their face is swollen, and the abscess has gotten into a really dangerous space. So you talked about children dying of brain abscesses from this condition, this completely preventable condition. So the pain and swelling is a big problem in this population if prevention is not there. Also, the cost of treating children in emergency situations in the emergency room, if prevention isn't there first, is very detrimental. Cost of an ED visit to the emergency department runs around $8,000. That doesn't include any treatment for the actual dental condition. That just gives you antibiotics and some pain medication. It doesn't actually treat the child. So prevention, which visits can range at less than $200, can prevent those really costly but not effective dental interventions. Treating young children also might require some behavioral interventions like sedation or treating them in the operating room under general anesthesia. Those are also really, really expensive treatments that could have been prevented. So early childhood prevention is key to preventing that. In this state, we have a lot of dentists who are committed to seeing children. There aren't a lot of dentists in general. We still are working on creating more dentists. But the rate of pediatric dentists in this community is very low. There are only 75 pediatric dentists, I counted the other day, in the state of Minnesota. So that means the majority of prevention has to be done by non-dentists, by these great community partners that we have, community health workers, RNs, PAs, in the pediatrician's office, in the family practice office. There's just not enough pediatric dentists to see all the children of the state. So that's why I'm really encouraged by all of these state partnerships that take on oral health as one of their main goals. Even in a community that has general dentists, if you have a child with a lot of dental cavities and they need to be seen under sedation or general anesthesia, oftentimes general dentists don't have privileges at hospitals. So these children are traveling 3, 4, 5 hours for care down to the cities or down to St. Cloud or Duluth to get the care they need, because only pediatric dentists can get hospital privileges to treat these children. So that's why this prevention is so important in the communities that they're in. We find that pediatric dentists, we have 2 to 3 years of additional training, but that means we should be seeing the really hard cases. That means most children should be seen in their communities, seen by general dentists, seen by the family practitioners, seen by the pediatricians, by the community health workers, in their Head Start groups. Places where they're getting care and access to services already is very important. So I'm very encouraged by the state's commitment, and I look forward to being supportive of that moving forward.
That was quick. I was like, whoa. My name is Connie Bi, and I've been with Head Start for 29 years. I went in as a nurse and didn't realize I would be spending the majority of my vocation and passion on oral health. And I'm really happy that Nancy covered the educational impacts and family impacts. And I am so glad that in 1 year you've got us so figured out, because Minnesota is really, really, really into caring for our children and the early intervention. And I could go on with stories, but I made an outline to stay within my 10 minutes or I would talk all day. So when people think about Head Start, they think of it as an educational preschool program. But it involves the entire family. And part of that is their physical and oral health care. And that's what I work so closely with. And I could never have done it all those years without sitting at the table a lot with all of the people who helped us out and that we partnered with, contracted with formally, talked with, got ideas from, shared ideas with, shared resources with, and that's how it works in rural Minnesota, but I'm also learning it takes that in the metro area as well. So we need to keep talking. So anyway, in Minnesota, there are 34 Head Start, Early Head Start, tribal, and child care partnership programs serving 17,047 pregnant women and children from birth to kindergarten entry. Now that was in the 15-16, call it the school year, but it runs on a federal cycle, so it's in those 2 years. There has been some expansion in the child care partnership areas, so those numbers have gone up. Head Start is the only federally funded preschool program. In Minnesota, the state also adds some funding to serve additional children. And along with that funding comes a huge set of program performance standards that are provided within the context of the family and the community. So if Head Start programs aren't involving families and the community, they're not going to survive. And for oral health, the standards require programs to track and report, and that's to Congress and the public, provision of oral health care for enrolled children to ensure that they receive oral health exams and follow-up treatment, oral health prevention and education, good dental hygiene practices and toothbrushing in the classrooms, which when you're partnering in communities, sometimes sends preschool special education teachers over the deep end. I'm just saying, okay? But they're getting more of a buy-in through spreading the word, like the Early Childhood Dental Network. And even now, child cares. Some child cares are, hopefully most child cares, Nancy? No, not yet. Not quite there. Some child cares are brushing their teeth as well. And we would be more than happy to help them find the resources to do it in a very hygienic manner. Anyway, I'm off on a soapbox. And we're also in Head Start required to assist families to find a medical and dental home, which is a huge challenge. And challenges related to this are an ongoing struggle for programs. Failure to meet the federal Head Start program performance standards around oral health and other issues can result in programs losing their federal funding. And this has not always been the case. It's not just if all the children don't get a dental exam, programs get their funding taken away, if you have systems that are totally out of place. But programs do get cited for it. And people like me who are responsible for it sit at the table like, oh boy. So in our state, the Minnesota Head Start Association has addressed this issue through their oral health project. Programs across the state have increased the numbers of children receiving dental exams, preventative care, and follow-up in a variety of innovative partnerships and collaborations. They've incorporated dental education and screening programs and advocated for policies to address the barriers to dental access for all Minnesotans. Because if we aren't getting the parents into the dentist, they're not going to take their children to the dentist. Does it always happen? Maybe not, but we try. So as I was preparing for this, it felt like I've been working on this forever, but it really has only been since 1999, which to some of you, I'm looking at you thinking, yeah, that is forever. But in 1999, the governor pulled together a task force to address, it pulled together people from across the state, like, what are we going to do about this access issue? And they were beating their heads against the wall and making a little progress, and it would go forwards and backwards. So in 2002, the Head Start Association had a forum, and it was convened by the Head Start Association, but it was a collaborative between the association and the State Head Start Collaboration Office and the Minnesota Association for Community Dentistry. Again, it's all about pulling partners together. And the goal was to heighten awareness and create a statewide agenda to improve access, education, prevention, and treatment services for Head Start children and their families. At that time, it was just to try to get Head Start in compliance. Sorry, Nancy. It was a long time ago. But back in 2002 now, stakeholders developed and released a statewide oral health action plan which inspired implementing innovative model approaches to oral health that included the development of a tooth book. There were no materials at that time that were appropriate in the reading level of Head Start parents, or even directed at that age group. So look how far we've come. Now they're all online on the Early Childhood Dental Network. It was printed and widely distributed across the state. I distinctly remember bringing box loads to child and teen checkups, as did many of my friends. And the second part of that plan was the Early Head Start Primary Prevention Oral Health Campaign. And they had consultants from the University of Minnesota and Marquette University develop a training program for early Head Start home visitors. The staff learned to conduct caries risk assessments on infants and toddlers and to teach age-appropriate preventative strategies to parents. So it's still going today. Home visitors are doing it. They're completing the form. We're tracking and monitoring it. They're working with parents on it, and they identify early signs of oral and environmental risk factors and make appropriate referrals to dental professionals. All the while trying to convince their local dentist to see the children when they get their first tooth. Not an easy task. The third part of that one was an Apple Tree Dental Head Start Teledentistry project. It was piloted in 5 Minnesota Head Start programs, and in this model, dental hygienists came out, provided on-site services that included x-rays that were transmitted. Now this is 2002, so it was innovative. Now, you'll go, yeah, right. The x-rays were transmitted to a dentist at a clinic who was able to diagnose and tell the parents right then and there where the child was at. And so they were able to prioritize care and make appointments for the child to go to a clinic and get care. A study was actually done on that, and it was quite successful, but maintaining it is a whole nother story. Apple Tree does use some teledentistry still. I talked with Deb Jacoby about that yesterday. But despite progressively improving rates of compliance, in 2006, the federal reviews cited Minnesota programs by the Federal Office of Head Start as being out of compliance on the performance standards related to dental exam rates, to which we all retreated. Oh, sorry, okay. And then, so again, the Minnesota Head Start Association partnered with even more friends to work on the community collaborative practice oral health model, to use collaborative practice dental hygienists to come to our classrooms and use the basic screening survey. They organized a basic screening survey training and got Gail could not remember the numbers that were trained at that time, but there were in my memory, about 25 of them available across the state. And now I learned in the previous session that they don't even know exactly how many are currently out there, so then I didn't feel so bad. But they were able to see a lot of children, and we could prioritize who really needed follow-up care. So an issue came up with that about, is that really a dental exam? We knew that the children were getting seen. They were getting seen by a calibrated dental hygienist, but we had to get permission from the state to count it as a dental exam and the Federal Office of Head Start. It was granted, and we were so happy about that. Since then, the billing issues around that have prevented programs from keeping that ongoing, but the capacity in the mobile clinic arenas have helped the ability for programs to bring dentists and hygienists out with their pediatric mobile equipment to do exams on site in a variety of ways. So they may do services at individual Head Start centers, or they may come to a site within the community that's arranged to the Early Childhood Dental Network. So there are a variety of ways to do that. It's still not perfect statistics, but it definitely has improved. In the program I worked in, at one point we were down to 72% of our children were getting dental exams, and it was not due to lack of effort. And they are now at 97% completion rate of dental exams. The dental follow-up treatment is, across the state, we're still at only 88%. So it's still got a long ways to go, but it was down to in the 60 percentile at one point. So programs and the Minnesota Head Start Association continue to explore and establish new and ongoing partnerships at the local, state, regional, and federal level with providers, colleges and universities, associations, coalitions, networks, state and federal agencies, nonprofits, and community partners. So when you think about pulling people together, you need to think about everybody. And sometimes there are people out there that you don't even think of, but if you partner with people, they know about them. So that's the value of partnering. So I just can't say enough about partnering with people for success. I'll pass it on to one of my partners.
Thanks, Connie. Hi, my name is Marsha Schroeder, and I'm a nurse with Horizon Public Health. I want to thank everyone for the opportunity to share, and I'd like to share a little bit of personal story and then some agency information pertaining to children's dental health. So first of all, getting back to the West Central Early Childhood Dental Network, or the ECDN as you've heard it been called already, that organization has personally helped me invest in children's oral health. I've been involved with the Child and Teen Checkup Program almost as long as Connie. I met up with her about 25 or 26 years ago, and we started working on collaborating the Child and Teen Checkup Program between Head Start, medical doctors, and the early childhood screening for schools. So we've been involved with each other for a long time. But working with community partners like the schools, Head Start, and healthcare providers, as well as I used to do child and teen checkup screenings myself. So it wasn't until I was assigned the job of going to the regional ECDN meeting that I really developed an interest in the dental issues for these children. So our ECDN brings a mixed group of people to the table. They all work in a different way to better children's lives. And through ongoing conversation at our meetings, I now better understand the big dental picture that includes working with the Minnesota legislature, and we heard quite a bit about that this morning, to encourage them to make changes that will ease our rural dental issues, to sitting down with a mom. One day I was at a social services office in Grant County, and one of the workers there, she was a social worker, brought me aside because I was there to talk about child and teen checkups, and her son had some real dental issues. They did not have dental insurance. Her husband was unemployed at the time and so forth. So it was like she just took me aback. I mean, I hadn't really sat down with a mom who had such a raw experience at hand and was still trying to solve that problem for herself and her child. It was heartbreaking to see that when you get down on the one-on-one basis. So there's a lot of work to do at both ends of the situation, both ends of the spectrum, with the families all the way up to the legislature. So a huge benefit of our ECDN is sharing ideas for effective public education and family outreach. I've come away with dental educational tools to help families at our Horizon Public Health counties. Oh, by the way, Horizon is a 5-county public health agency, Stevens, Traverse, Grant, Pope, and Douglas counties. So we're in the Morris, Alexandria area, Glenwood. Yeah, right where the blizzard is raging. I see it's snowing here now, so I'm going to talk a little faster. No. So one of our ideas is ongoing. Each month, Horizon, our public health agency, gets our Catch 3 download from the DHS, you know, for all the children that are eligible for the child and teen checkups. So we have to send a letter to them and make phone calls, but in our letter we include a letter from the tooth fairy to the 12-month-old child. And so, as you might imagine, it encourages the parents to take that child to the dentist at that age or at the eruption of the first tooth. So that's been kind of a fun thing to do. Another way children and public health benefit from our ECDN is through the dental hygiene outreach clinics, and we've talked about that quite a bit already. The clinics supply dental services for families who are unable to find a dentist who will take their children as patients. So when the public health nurses or the nurses are screening children through the child and teen checkup, it's especially clear that dental services are needed. If they have the mobile clinics, they've at least got a place to refer that family to if they need to get some services. Because quite frankly, there are a lot of dentists in our area, most dentists in our area will not take families who have a payment source of Prime West is our Minnesota healthcare program in our 5-county, in our region actually. So the commitment of the West Central ECDN program under Jane's leadership over there has encouraged me personally to be committed to children's dental health. Attending the meetings and learning from all the members, like fellow public health agency, health plans, Head Start, and early childhood initiative people is invaluable. And so I now have available to me education and tools to further the goal of the dental health for all our young children. I've shared that information with our public health screening nurses and WIC staff, and hopefully have been able to instill in them some of the urgency and enthusiasm I now feel for the children's oral health. So that's kind of my personal background around the ECDN, and now I'd like to share a little bit how I've incorporated that into my work. So part of my responsibility with the Child and Teen Checkup Program is to make annual visits to clinics, to the medical providers. So this year, in addition to just reviewing the general aspects of Child and Teen Checkup, I chose to focus specifically on oral health and dental fluoride varnishing, and those two components of a Child and Teen Checkup, and they are both listed on the periodicity chart as components for a Child and Teen Checkup. So they are the health benefit, or a Child and Teen Checkup is the health benefit for children 0 to 21. Are most of you familiar with the Child and Teen Checkup program? I see some of you nodding, some not so much maybe. So it is a federally funded program that ensures well child checks for children who are covered by medical assistance or the Minnesota healthcare programs. And all of those children 0 to 21 are eligible for that program. So it's the challenge is to get clinics to complete all of the components that are suggested by the American Academy of Pediatrics and the CDC. And they've added components through the years. Rarely will they take a component away, although that has happened, but they've now added oral health check from a doctor has always been on the list, but now they've added fluoride varnishing as a recommendation. So that's like right before they would require it, they put it down as a recommendation. So it was interesting when I went to the clinics and I started talking about that. None of the clinics I visited in our 5-county area are doing fluoride varnishing at the doctor, and yet I asked them, or I told them, you know, one of the things you need to consider is that a child younger than 5 is much more likely to come to the medical doctor than they are to go to a dentist. You have a primary care opportunity here for you to do that check in the child's mouth and find out if there's problems and what you need to do about that, and to make referrals when you do find problems. So now she's giving me the evil eye. I thought this was going to be short, Jane. I guess sorry. So just to give you a little perspective, in 2017 there will be 606,169 children between the ages of 0 and 21 in Minnesota who will be eligible for child and teen checkups. And that's all of those kids, simply by being on medical assistance, are put in the at-risk category for having dental problems. So fluoride varnishing is something that I really do want clinics to start. I'm going to be following up with them later in the year. It's something that our healthcare plan will pay for, and so if we can get that started at the clinic, I think that's going to be a big help in preventing and stopping dental caries. So I think at that point I better stop, other than saying our West Central ECDN is a terrific oral health resource for the agencies in our area. So changes need to come in the number and availability of dentists, of course, who are willing to serve MA population, public education about the importance of oral health, and then in the support available to the individual families struggling to get the care for the children they need. So that's where we're at with that, with our ECDN.
All right, good afternoon, everyone. My name is Annie Vegan. I work in public health as well as a registered nurse. Little did they know, I like to shake things up just a little bit on this panel. So I've been sitting for a little while. Why don't we just all stand up and just kind of move and stretch our legs just a little bit. I think that feels good after lunch, and just get a little stretch in and kind of keep your focus just a little bit. Yeah. All right. Well, thank you for coming today. Again, my name is Annie Vegan. I'm a registered nurse. I work for public health. We formed a community health board with 4 counties. It's Clay, Wilkin, Ottertail, and Becker. So again, we're combined counties along with Horizon Public Health as well. And I work with the Child and Teen Checkup Program also. I was honored to be asked to participate in this panel to promote key preventions and strategies to improve the overall outcomes of the young children and our young adults as well. So looking at, putting things together for this presentation, I was coming across some words, and one of them was prevention. And coming across on the Webster's own dictionary is the action of stopping something from happening or arising. And we all know, working close in public health for about 10 years now, that is what we hear a lot in public health. Prevention, prevention, prevention. It just gets molded right into our head. And also, another thing about public health is we learn a lot of acronyms. I don't know if you guys are familiar. That is another learning curve when you walk into the public health world, is acronyms. It is so, one thing that truly stands out to me as well is oral health. It is so important. I can recall a situation that happened earlier in working in public health where a child an older sibling was putting Mountain Dew into the bottle of the younger child, about 18 months of age. And I just couldn't believe it was happening. You know, the child was having a fit, and to calm this child down, what the older sibling did was to put the Mountain Dew in the bottle, and they thought that was the solution. And it was just astounding to me, and that was really, really eye-opening that this really happens out there. And I thought, wow, you know, we need to stop this. We need to, you know, but they don't know any better. That older child didn't know anything, thought it would just calm her, you know, his little brother down, and so that's what he was taught to do. So with that, when that happened, I thought we need to, you know, get on the education piece and start from when they're young, when maybe these mothers are pregnant, and, you know, that's when we need to start with the education piece, for sure. And that's why I do clinic visits, and I provide education to the families and show them the importance of oral health, and also to find a dental home. And one of the things that the last presentation that really struck out to me is, where is a child's dental home? And it's in their own home. And I mean, I thought that really struck out to me, because it is very important. The dental home is in our own homes, and that's what we need to focus on. So tooth decay, it is very preventable. Children and adolescents with untreated tooth decay can experience pain, school absences, difficulty concentrating, poor appearances, low self-esteem, and other complications as well. Children and adolescents on Medicaid are less likely to receive preventative dental services and are at high risk of developing childhood caries as well. So my goal is on to the clinic staff is to help prevent these oral problems at a young age with focusing on the child and teen checkup fact sheet. As we know, we go into the clinics and we promote this about the requirements that the providers have to educate our families. And then also with the help of Minnesota Department of Health and Department of Human Services as well. And accessibility, that's another term that I was looking up into the Webster's Dictionary, and what do you think accessibility means? Providing access. It's one thing I struggle with. I struggle with the dental accessibility in our northern region for our kids that are on the Minnesota healthcare plans. It's hard. It's very, very hard. There are no dentists that do take our children. We have 18,000 kids in the 4 counties that I work with, and we have a waiting list of about 1,700 kids at just one clinic. They're booking appointments into July of 2017. These families are just throwing up their hands and just saying, forget it. And so we can't let them down. We have to change things. So then it goes back to my word of prevention. And we have to start young. We have to start when these mothers are pregnant and start educating them at that time on bottle use, bottle mouth tooth decay, how we need to get them off a bottle at the age of 1 and no later, transferring from the bottle to the cup, not the sippy cup. Those are some important pieces, and most definitely the ECDN has definitely helped out provide these key components for us. The ECDN has helped they've helped with dental kits for us, they've helped with transition cups, so not sippy cups, but transition cups to get these families to teach the kids to drink from that regular cup and not the sippy. It's been just wonderful working together as a partner with the ECDN. Let's see. My third word is promote. So to promote is defined as to contribute to growth of prosperity. So how do we promote oral health to the best of our ability, given the resources and lack of accessibility to dental care for our children that are very high risk? Well, one of the things that comes to mind is the fluoride varnish. We have been utilizing our resources from the ECDN and MDH promoting the application of fluoride varnish in as many places as we can. As Marsha had mentioned, we are promoting it in the medical clinics because these are where these kids go. They actually, when they're sick, they can actually go to the doctor. Okay, well, let's just put on some fluoride varnish. It takes less than 2 minutes to get up to apply the varnish, and it has evidence that it works as well. It helps prevent those cavities, so if the child does have a cavity, at least it'll stop it from growing and getting worse, and also from preventing them from forming as well. We also promote it into our family home visiting at Public Health. I don't know if you're aware of some of our programs that we have, family home visiting programs such as Healthy Families America, the Nurse Family Partnership Program, Head Starts, WIC, and more. And so those are some of the things that we're getting the nurses out there into the homes. They make the connections with the families, and we can have them start applying this dental varnishing on the children's teeth right then and there. So I think that's so cool. In closing, I just want to say on behalf of the Child and Teen Checkup Community Health Board, I would like to stress our wonderful working relationship with the ECDN, and Jane is our leader. It's just so wonderful. Cannot thank you guys enough for the wonderful resources that they give us and the opportunities and the partnership of preventing, promoting, and increasing accessibility for our children that we serve together. We know together we make a huge difference on these kids. I can't imagine where we would be without this partnership. And together we are a partnership for oral health. And I also just want to say that, and it starts with us. And so as the theme of this year's Oral Health Coalition, it does start with us for sure. So thank you guys for coming today and listening to us. Appreciate it. And
give a hand for our panel. I think you guys did a great job, and we wanted to leave some time for questions because I suspect some of you may have questions about the specific activities or other ideas, or we actually would welcome some ideas from you too. If you have ideas or suggestions of ways that we can all work together to continue to address the issues with early childhood oral health. So I will open it up to whoever would have a question. Yeah, yes.
I would just make a comment. I'm Pat Lunton from the University of Minnesota, and the dental school has, the dental outreach programs, of course, and they're going out state. And I know that they have been looking at trying to expand those programs. So I mean, I'm not the person who makes that decision, but when you're saying you have those kinds of numbers, that you have 1,700 children on a waiting list, it might be something to do to reach out to them, especially, there's been some interesting things I know that have been done. I'm actually working in clinical research, so I'm not working with the outreach programs directly, but I know that, for example, I think it was in Wilmer, they actually worked with one of the local hospitals and put a chair and stuff in there. So if you can identify some space, it might be worth reaching out to the school because they really do want to expand those outreach programs to get some dental students up there.
And I can respond a little bit to that. And we have actually had meetings with the U, with Dr. Assail and some of the organizers of that particular program. And I believe they know that we are very interested. We reach out to them routinely. And it's always great to bring new partners into our area as well. So if you have any inside info that we don't know about there, we'd welcome that too, as far as encouraging them to come out to our area. So good. Any other questions? Yes.
I'm Heidi Oliver. I'm with UCare. I was just curious when you were talking about the visits you've done to medical offices and encouraging them to do fluoride varnish in the well child visits. How have they been receptive to that? Have you seen success with that? How's it gone?
I've recently done a survey in all my clinic visits, and I serve about 37 clinics in the counties, in the 4 counties, and it's about half, so it's about 50-50. And it's kind of interesting because it's not, for instance, like we have Essentia and Sanford, those are our primary clinics that we have. We also have Lake Region and Fergus Falls too. But like it's not, it's not just Essentia clinics, it's not just Sanford clinics, it's just kind of hit or miss. And so I have some clinic managers that are very, very close to kind of turning the corner, and we're hoping in 2017 that we can definitely get there to start with that, to definitely get that program going with the dental varnishing. So it's about 50-50, but they're very receptive to it. A couple years back, they were not so much, but I think they're seeing the difference and that the lack of dental access for these kids, so I think they're getting the idea.
Nancy?
I just wanted to say that we have been working on this for quite a few years, and I think the key to it is having someone locally, like Annie, go talk to the clinics, because Jane was doing that for a while, and she isn't local as far as, local is a funny thing, because you have to be from that town in order to be considered local. You can't be from the next town down the road. And so Jane has been working really hard at it, and has had some successes. But I'm really hopeful that Annie and Marsha will be even more successful, because they're right from the community.
Any other questions?
I should have included this, and I thought of it as I was hearing everyone talk, but one of the things that we found so beneficial is that, and people don't always think of this, is bringing oral health care to where children already are is so beneficial. And until you see it yourself, it's hard to imagine. And I'll give you an example. We were collaborating with early childhood programs in one center, and we had Head Start programs there. There was special ed programs there, ECFE, all in one building. It was a school district building, but it was not in the school. So I got permission when collaborative practice came into play to bring in a collaborative practice dental hygienist into the building. And that day, the eyes were so open, because they were like, ooh, I don't know. You know, it's not our job, that's the parents' job. That wasn't Head Start people, okay? But they gave us an unused bathroom to be in for privacy. And I was like, oh, I can do this, okay. So I got a kitchen cart, you know, you can clean it. I got 2 office chairs and a really good light. I had a sink. I got tumbling mats that we used in the classroom to block off the urinal so the kids didn't see it. They thought it was great. And every single child complied. And we had a teacher from a neighboring center that was so jealous that it got to be there that she's like, I've got this autistic child, and the grandma's been trying to get him in. They can't get him through the door. She brought him, and Mary Lou Olson, whom many of you may have met, literally did the exam on the hallway floor. He was in a tantrum, was out of a tantrum, and loving the Dory-style puppet. And Grandma cried and cried and cried. She had to remove herself. She was so happy, and we were happy. We were all so happy. And that's the benefit. And what happened when the children had to actually go into the clinic for follow-up care is they're prepared. They recognize the person that they saw on site, and now it's progressed from a plastic box and working out of a bathroom and 2 office chairs to Caring Hands being a real live dental clinic with portable equipment thanks to grants. And they bring out dentists who happen to be twins, so whoever shows up is always their dentist. And when they need to go in for care, they're the best patients in the office. And I think that it's my belief that it should be part of school health as well. And even if a school nurse agrees with it and tries to proceed, sometimes there's school boards like, ooh, that's the parents' job, you know, it's not our job. And so I think we all just need to be really good advocates for getting care out, like going out to home visits and bringing the information to where people are.
Thank you, Connie.
I know I promised not.
You're good, you're good. And we are about out of time. I think we're to be wrapping up here at about 1:30 so that we can start the next session. We're a little ahead of schedule today, I think, due to the weather. Yes, did you have one more?
Yeah, I wanted to say one thing. One thing that I didn't say that I should have was that without Jane as our coordinator, this also wouldn't happen, because it's hard to get people together to do the work if you don't have somebody who's that's their responsibility to do. So a coordinator is just so important. And Jane's not only the coordinator for this ECI, she is the coordinator for the expansion. So each of the other ECDNs has a coordinator, but Jane coordinates it all. And so I think that's really helpful too.
Well, thank you, Nancy. And honestly, I don't think she means to say Jane so much as she does as a coordinator, which I do believe is, you have to have a hub for that. So thank you all, but I will also say that we're really fortunate that our partners do the work, and I think that's the other part of it. A coordinator is just that. You coordinate things. The partners do the work, and without that, we wouldn't be successful. So, you know, it really is a good collaboration, and it's a good partnership. So thank you guys for coming, for sticking it out with us. I bet you there's probably half the people have gone home now that the snow has started, so we'll see if there's still any life out there when we leave this room. But Dr. Sarvis will be here doing the next session also, which is oral health across the lifespan. So if we want to take a quick break, and she will be right back here in this room here in just a few minutes. So thank you, guys.